Good afternoon. My name is Holly Kramer, and I'm president of the National Kidney Foundation. And I just want to say welcome to the Spring Clinical Meetings plenary session. I want to thank the program committee who acted quickly to move our annual conference from New Orleans to virtual gathering in order to protect all of us and your patients from COVID-19 spread. Certainly wasn't easy to make this meeting virtual, but I'm really grateful to the team for pulling this monumental feat off. It's never easy to be the first to do something new, but they have been able to provide a robust interprofessional program virtual. We have a really busy agenda for this session, so let's just get right to it. I want to introduce you to the Shaul G. Massry Distinguished Award recipient. This lectureship was established to honor Dr. Shaul G. Massry for his scientific achievements and his contribution to the kidney healthcare community and to the National Kidney Foundation. This year's recipient is Dr. Joe X of the University of California in San Diego. He's been a tireless leader in clinical research, and his work is invaluable to advancing kidney care. He's been a mentor to many investigators and helps to hone their work. He's truly walking in the footsteps and legacy of Dr. Massry. He's professor of medicine and chief of the Division of Nephrology at the University of California in San Diego. And he's also a staff physician at the Veterans Affairs San Diego Healthcare System. His research has really focused on two main areas. The first is understanding the contributions of kidney tubule disease on kidney disease progression and evaluating new approaches to treat kidney disease-related bone and mineral disorders. He has demonstrated the limitations of using biomarkers for kidney disease and for the link between kidney disease bone and mineral metabolism and cardiovascular disease outcomes. He was also an investigator in the SPRINT trial and has received numerous NIH grants to study kidney disease and its link with cardiovascular disease. And he's an incredibly nice person. So let me introduce Dr. Joe X.
Thank you, Holly, for that very warm introduction. And thank you to all of you. This is also my first time doing a plenary talk virtually, and I'm deeply appreciative for you attending the talk rather than my ability to be with you in person in New Orleans. On my computer, I see we have over 600 people joining us. And so I very much thank you for your attention. And I look forward to sharing some of our data. So the title of my talk is the Prognostic Insights from Non-Invasive Assessments of Kidney Tubule Health. And I will begin to move through here. Briefly, I wanted to disclose that I'm a principal investigator on a investigator-initiated research project that's sponsored by Baxter International. This study studies different ways of providing peritoneal dialysis on fluid removal and is not directly related to today's talk. Before moving to the content of my talk, I wanted to share how deeply honored I am to be this year's recipient of the Shaul G. Massry Award from the National Kidney Foundation to give this plenary talk. I once had the privilege of meeting Dr. Massry and just wanted to alert the audience to his many contributions. He was a division chief at University of Southern California for over 25 years. And like Dr. Kramer is a past president of the National Kidney Foundation. He's made many seminal contributions, particularly in the area of calcium, phosphate, and magnesium and PTH regulation, and how those are altered in the setting of advancing uremia. And for this work, really is recognized as an international leader in CKD mineral bone disorders. And because of his advocacy for kidney care and kidney research, really for nephrology more globally. His leadership and advocacy for nephrology research that really matters to our patients has certainly improved our renal community and made it a richer place to live and to work. And so I am deeply honored to be the recipient this year. So the goals of my talk are really to describe an idea that my colleagues and I had maybe 6 or 7 years ago about trying to identify the global health of the kidney beyond eGFR and albuminuria, and understanding the contributions that those measurements may make in terms of understanding consequences of kidney disease, whether it's risk of progression of chronic kidney disease, cardiovascular disease or other comorbidities, and perhaps also in the long term to be able to monitor kidney disease through new ways. So the talk will really focus on recent data that we have put together, most of it published, some of it still unpublished and appropriately referenced as such in this topic. But more globally, what I'd like to do is ask your allowance to allow me to do more breadth than depth so that I can really focus on telling a story. I will also take the liberty of showing our own data, but interspersing similar data or related data from others, again, with appropriate referencing. And I'll take the liberty to jump between different study populations relatively frequently. And of course, I'm open to questions about the depth of these studies or the populations as needed as questions arise after the talk. So to begin, I think most everybody on this presentation will recognize this slide, which was very important for our field, work that was put together to actually define what we mean when we mean chronic kidney disease. Published in 2002, the KDOQI guidelines that characterized the stages of chronic kidney disease largely by the severity of eGFR or other known damage at the earlier ranges of CKD. And this was really integral for allowing us to discuss chronic kidney disease from one paper to the next or one research study to the next and make sure that we were comparing like patients. Like things that are great but are just starting out, this has, of course, since been advanced. And the largest way that this has been advanced, of course, is because of the addition of albuminuria as an additional measurement of kidney function. And really that work is driven by this seminal paper published by Dr. Astor that used a very large study population within the CKD Prognosis Consortium and evaluated eGFR and risk of end-stage renal disease on the left. And of course, at the bottom in this meta-analysis, you see a very strong relationship of lower eGFR with risk of end-stage renal disease that will not surprise anybody in the audience. But more importantly was the data presented on the right side of this figure, which again, through this very large combined data set, really demonstrated definitively that worsening proteinuria or albuminuria was also extremely strongly associated with risk of end-stage renal disease, independent of eGFR or other risk factors. Based on these data, the KDIGO group in 2013 revised the original CKD staging criteria for chronic kidney disease to this heat map that we've also all become very familiar with. Again, we now have stages of eGFR, as can be seen on the left, with worsening eGFR going through increasing stages of risk, and worsening albuminuria horizontally. And this heat map allows us not only to define the severity of eGFR and albuminuria, but once chronic kidney disease is diagnosed, it also allows us a way to define risk for adverse outcomes, whether they be end-stage renal disease or cardiovascular disease. And yet, if you step back, one realizes that both eGFR, largely based on creatinine or sometimes cystatin C, and the urine albumin to creatinine ratio primarily focus on the health of the glomerulus. eGFR primarily for filtration or glomerular function, and albumin to creatinine ratio really is glomerular injury. So we were struck largely from our clinical observations that often when individuals had relatively preserved kidney function, but required a kidney biopsy, either in the setting of a kidney transplant or for diagnosis of de novo chronic kidney disease, we would not infrequently see biopsies such as the image that you're seeing on the right, where the eGFR remains relatively preserved and the proteinuria may not be so severe. And we were quite surprised to see the severity of tubular atrophy and tubulo-interstitial fibrosis. And we know that, that from biopsy studies, whether looking at, again, kidney transplant patients, patients with lupus nephritis, patients with IgA nephropathy, that the severity of tubular interstitial fibrosis on biopsy is among the strongest risk markers for risk of loss of kidney function and end-stage renal disease. The finding that we often see tubulo-interstitial disease that can be moderate to severe, despite the fact that kidney function is based on eGFR remains preserved, was really quantified to some degree by this important study that was published by Dr. Rule in the Annals of Internal Medicine. Dr. Rule had a unique opportunity in that his center had collected over 1,000 individuals who were healthy kidney donors at the Mayo Clinic. And all of these individuals had measured GFR prior to transplant. And at the time they went to the operating room to donate their kidney, a wedge biopsy was done, providing pathologic data that allowed investigation of the pathologic findings in these relatively healthy individuals and relatively healthy kidneys. And perhaps not surprising, as you can see in the table at the bottom, if you quantify the prevalence of interstitial fibrosis greater than 5% on these healthy, relatively healthy kidneys, there is a relationship with more interstitial fibrosis with increasing age of these individuals. But what was surprising is that once one accounted for age, there remained no association between the measured GFR and the degree of interstitial fibrosis. Certainly, as patients have more advanced chronic kidney disease and begin to lose eGFR, of course, at some point, the loss of eGFR and the degree of tubule disease are likely to be correlated. But in these individuals with largely preserved kidney function, I think these data really show that these two measures of kidney function, one based on biopsies and looking at the tubulo-interstitium, and another a blood biomarker that estimates GFR, are relatively poorly interrelated. So that led us to ask the question about whether or not there may be a way where one could non-invasively characterize the health of the kidney tubules. And if that were possible, if that in itself would provide prognostic information about risk, whether it is loss of kidney function, mortality, cardiovascular disease, or other comorbidities that we know are strongly related to chronic kidney disease. So if I can frame a few hypotheses that I will address through our talk. Our first hypothesis was that we could, in fact, non-invasively measure tubule health, and that these markers would predict loss of kidney function independent of glomerular markers of kidney disease, by which I mean estimated GFR and albumin to creatinine ratio. Secondly, we hypothesized that these tubular health markers might also predict CKD-related complications independent of these glomerular markers of eGFR and albumin to creatinine ratio. And then thirdly, we had an aspirational hypothesis with the hope that ultimately, if we were successful, that these tubular markers may allow differentiation of different types of causes of creatinine rise. Perhaps they might ultimately allow differentiation of, for example, acute interstitial nephritis versus glomerular nephritis, which of course could both raise creatinine, but may do so through very different pathways. Or we might be able to differentiate when creatinine is elevated for hemodynamic reasons and pre-renal azotemia versus intrinsic kidney damage. So I'll work through each of these hypotheses and show you some data in support of each. So let's begin with the first hypothesis here, looking at tubule health markers and loss of kidney function over time. So most of the data I'll show you today stem from a research grant that was supported by the National Institutes of Diabetes and Digestive and Kidney Disease. We came to the NIDDK with these hypotheses and were fortunate enough to be supported by an R01 grant. And we leveraged data that were available to us within the SPRINT trial. And so since much of this talk will utilize the data from the SPRINT trial, I thought I would begin by a quick summary of this trial. I think many of you will be familiar with it as well. SPRINT is a recently completed randomized clinical trial that recruited just over 9,300 individuals that were all hypertensive and evaluated whether randomization to an intensive reduction in blood pressure to a target less than 120 versus a standard blood pressure target of less than 140 would prevent development of chronic cardiovascular disease as its primary endpoint. Because of the strong relationship of both blood pressure and cardiovascular disease with chronic kidney disease, the SPRINT trial actively sought to recruit patients with chronic kidney disease defined as an eGFR less than 60 and as low as 20 milliliters per minute per 1.73 meters squared. I have some of the key characteristics on the left. Their mean age was 68. Again, because this was a hypertensive trial, all of these individuals were hypertensive. All were selected for having higher cardiovascular disease risk, which could be either known prevalent cardiovascular disease, a high Framingham risk score, the presence of chronic kidney disease, or being older than 75. And again, with the work to recruit individuals who had chronic kidney disease, in the end, almost 30% of this trial population had an eGFR less than 60, which constituted just over 2,500 individuals. And it's these 2,500 individuals that were the sample that we used for the data that I'll show you today. So all of the individuals we're looking at had an eGFR less than 60 in this trial. Now, we thought for some time about biomarkers that might be useful and accessible primarily through the urine to reflect injury within the kidney that might also give us different insights to what's happening in the kidney. And I have quite a long list here, and I won't address all of them. I think, again, many of these biomarkers may be known to many of you who are working in kidney disease. But we selected some of these as markers that would give us insights to kidney tubule injury on the left and tubule function on the right. And while more work has been done looking at markers of kidney tubule injury, both in the setting of acute kidney injury and to some degree in the setting of chronic kidney disease, we were equally interested in whether we could characterize abnormalities in how the tubules were functioning and what that might tell us about kidney disease prognosis. And so I'll try to keep apart injury and function in two large categories as I move through the remainder of my talk. And we'll come back to some of these biomarkers in more detail. So as we started our work, other groups were doing similar and parallel work that was quite important. And many of these biomarkers that primarily reflect injury to the kidney tubules had begun to been studied, again, initially to see if they could predict prognosis about acute kidney injury earlier than creatinine or the consequences of acute kidney injury. And shortly thereafter, they began to be studied in outpatients, either looking at risk of incident chronic kidney disease or among individuals with chronic kidney disease with risk of CKD progression. This study that I've highlighted here is work from Dr. Xu and his group in San Francisco within the biomarker consortium, which I think was a very important paper in this topic because, again, it focuses on outpatients within the chronic renal insufficiency cohort that all had chronic kidney disease at baseline and had very good adjudication and follow-up for development of CKD progression and end-stage renal disease. And it was also among the first studies that actually measured multiple injury biomarkers at the same time. And you can see in these main models that when the relationship of these biomarkers with risk of CKD progression defined as a halving of eGFR from baseline or the development of end-stage kidney disease, while these biomarkers were associated with CKD progression in unadjusted models, when these models were adjusted for the very reasonable risk factors that you see listed below, these associations were attenuated and rendered no longer statistically significant. And I'll mention here for the first time that these models are also adjusted for albumin to creatinine ratio and estimated GFR. Some might argue that that's perhaps over-adjustment because that's adjusting for other aspects of kidney disease at baseline. But of course, the clinical question here is whether these additional urine biomarkers of tubular injury would help provide prognosis above and beyond what the clinician has at the bedside with eGFR and albuminuria. So interestingly, despite studying 3 separate markers, well-known markers of tubule cell injury, in the CRIC cohort, there was no independent relationship of higher urine concentrations with these biomarkers of injury with loss of kidney function over time. So in our work then in the SPRINT study, we began by looking at a similar question. Again here, I'm showing you adjusted models, again adjusting for demographics, which intervention arm the studies were randomized, urine creatinine to adjust for tonicity, other CVD risk factors, and again, albumin to creatinine ratio and the estimated GFR. And on the left here, I show you the 5 biomarkers that we had measured in the urine at the baseline visit of the SPRINT study. And all of these mark different aspects of kidney tubule cell injury, inflammation, and repair. And very similar to the findings in the CRIC study, once more here, higher urine concentrations of these markers of injury were not independently associated with linear decline in eGFR as the endpoint in this model. But I want to characterize that in relation to the 3 biomarkers that we studied that evaluated tubule function. Again, these also measured at the baseline visit of the SPRINT study. And here, unlike the markers of injury on the left, 2 of these biomarkers were indeed associated with more rapid loss of kidney function over time. Taking these in reversed order, the first was alpha-1 microglobulin, which I'll describe to you in the next study. Higher urine concentrations of alpha-1 microglobulin were independently associated with more rapid decline in kidney function. And in contrast, uromodulin, another biomarker of tubule function, was also associated with loss of kidney function, but the direction was in the opposite direction. So here, lower concentrations of uromodulin were associated with more rapid decline in kidney function over time. And once more, these associations are independent of eGFR or albuminuria or the other risk factors that you see listed below. Okay, so just 1 slide each on these 2 biomarkers. So the interest that we had in alpha-1 microglobulin and beta-2 microglobulin initially when we measured them for our study was to see if they may be useful as a marker of proximal tubule reabsorptive capacity. Both of these are small proteins that are found in the bloodstream and are thought to be freely filtered at the glomerulus, similar to creatinine. But unlike creatinine, these 2 proteins are avidly reabsorbed at the proximal tubule, such that in most healthy individuals, there's very small concentrations of these proteins ultimately in the urine. And we had preliminary data evaluating these biomarkers in individuals with HIV who were treated with tenofovir, a known proximal tubule toxin, showing that treatment with tenofovir appeared to increase the urine concentrations of these proteins. And again, when tenofovir was held, these biomarkers would go down in the urine, suggesting that perhaps they were useful markers of proximal tubule reabsorptive capacity. And so the idea here was to characterize the kidney tubule's function in terms of their ability to reabsorb proteins that are filtered into the urine. So once more, the idea is that if there's a problem with reabsorption, less of this would be reabsorbed, and the concentrations of alpha-1 or beta-2 microglobulin would be anticipated to be higher in the urine. The other protein that I mentioned several slides back is uromodulin. This is a well-known protein in our field. It's also known as Tom Horsfall protein, and it's well known as the most abundant protein in the urine in individuals without proteinuria, without glomerular disease. And the literature around uromodulin is quite vast. There's a lot of discussion about the function of this protein. What's clear is that certainly genetic abnormalities in uromodulin can lead to kidney disease. It's the genetic gene that's altered in medullary cystic kidney disease. The other thing that's very useful about it for the purpose of this study is the only part of the body that expresses uromodulin is the thick ascending limb of the loop of Henle and the distal convoluted tubule. So it's a protein that's very specific to generation in the tubules. It's known that it's located on the luminal surface, and it's thought that it interacts with this gel-like membrane on the inside of these tubules in the cilia, and it's thought by some investigators to be important for prevention of adherence of bacteria and prevention of E. coli. It may be also important for generating a water barrier, if you will, to make the thick ascending limb of the loop of Henle impermeable or less permeable to water in this part of the nephron. And so we were interested in this protein for several reasons. Again, it is only produced in the tubules themselves, and we were intrigued by data such as these here, published in C. Jason several years ago, showing that greater urine concentrations of uromodulin on the y-axis were associated with larger kidney volume and larger kidney length. And we had preliminary data in other studies showing that higher urine concentrations of this biomarker in itself seem to be associated with risk of CKD progression. And so perhaps this is a useful protein to characterize the kidney's reserve in terms of its size here, and perhaps its function in terms of protein generation and protection from infection. So again, another very useful and interesting aspect of urine uromodulin is that unlike albuminuria or alpha-1 microglobulin or NGAL, in this case, higher urine uromodulin appears to be a good thing rather than a bad thing. And so statistically, it's quite useful because it becomes clear that you're not marking general proteinuria, but rather something that's specific. On the heels of these interesting findings of two biomarkers that seem to characterize kidney tubule cell function with more rapid loss of kidney function, an investigator in our group who's primarily interested in future risk of acute kidney injury raised an interesting hypothesis that we wanted to follow. And the idea here is that perhaps AKI could be useful similar to a kidney stress test. The idea is that, of course, routine creatinine-based eGFR is not necessarily the maximum GFR that individual can attain at a given level. And there have been studies that demonstrate this with IV infusion of amino acids or high protein loads, showing that patients can actually increase their GFR in response to protein stimulus. And maybe the analogy is something like a resting heart rate or a resting tidal volume, that the measurements that we get at rest do not necessarily give us a true sense of the kidney's capacity. And other than doing infusions or high protein loads, it's quite hard to know what the kidney's true capacity is. In the setting of the SPRINT trial, we thought that perhaps AKI was a useful marker of a kidney stress test, meaning if one acutely lowers a patient's blood pressure with more intensive blood pressure lowering, and then that individual has an additional stressor, whether it's an acute illness or bleeding or diarrhea, why is it that some of those individuals may develop acute kidney injury while others do not? And so we thought about this really as a kidney stress test, if you will. And so the hypothesis here was whether or not having evidence of tubule cell injury or dysfunction at the baseline visit of SPRINT would tell us something globally about the health of that kidney. And if individuals seem to have abnormalities there, whether they would be at higher risk of acute kidney injury during SPRINT follow-up, even though these biomarkers were measured at the baseline visit where individuals were coming in at times of relative health without acute stressors. And what Dr. Bullen in our group found and recently published in Kidney International, the main findings of his paper are summarized here. Again, looking at the 5 markers of tubule cell injury that we measured at the baseline visit of SPRINT, none of these were independently associated with risk of future acute kidney injury. And in contrast, once more, urine uromodulin and alpha-1 microglobulin, as measured at the baseline visit of SPRINT, were again relatively strongly and independently associated with future risk of AKI, independent of eGFR and albuminuria. So once more here, the biomarkers that seem to mark function of the kidneys rather than injury at times of health seem to be more strongly associated with AKI in this setting, similar to eGFR decline. Now, of course, there are other markers of tubule cell function, and some of these may be closer to clinical practice. There are several that we're interested in measuring in future work that we have not yet characterized within SPRINT or our other studies. But I wanted to just bring up two studies that I think are similar in theme and show that others are thinking in the same way. There are now several papers that have compared the relationship of CO2 concentrations on a blood specimen or on a blood gas with risk of CKD progression. This paper that I've chosen here was from a large study in South Korea that studied over 2,700 kidney transplant recipients, showing again that lower CO2 concentrations on a standard blood test was strongly associated with future graft loss, again independent of eGFR, albuminuria, and anti-rejection medications, other than other risk factors. And on a similar theme, Dr. Raphael and his group recently measured urine ammonium in the ASK trial. And of course, urine ammonium is produced by the proximal tubules and then combined with hydrogen in the distal tubule as the kidney's main mechanism of excreting acid. And once more here, individuals that had lower urine ammonium concentrations, perhaps another marker of the kidney's ability to generate and regulate acid-base control, were at higher risk of dialysis or death. And so across several biomarkers looking at the function of the kidney tubules, there appears to be a consistent signal with higher risk of loss of kidney function. So what about other CKD-related complications? And here I'll focus primarily on cardiovascular disease. Again, cardiovascular disease was the primary endpoint of the SPRINT trial. And so we had the opportunity to have very good capture of the CVD events that occurred after the baseline visit in SPRINT. And these were all adjudicated by pre-specified criteria and a panel of experts that were adjudicating these endpoints in the same way. Once again, we had decided to measure the biomarkers that I'd already showed you in about 2,500 individuals with chronic kidney disease in baseline. So the data I'm showing you are limited to those individuals with chronic kidney disease. And among these individuals, there were 305 CVD events during the approximately 3.5 years of follow-up that we had after the baseline visit in SPRINT. So once again here, we have a similar table. We again have the injury biomarkers on the left, and on the right, we have the 3 biomarkers of tubule cell function, except now the endpoint is cardiovascular events. And I'm showing you the hazard ratios and 95% confidence intervals as compared to the linear eGFR decline that I'd shown you in the previous studies. But the message is otherwise quite similar. Once more here, despite measuring 5 different biomarkers of tubule cell injury at the baseline visit of SPRINT, we found no association of any of these biomarkers with risk of incident CVD in adjusted models once accounting for eGFR, albuminuria, and the other risk factors that you see listed. In contrast, once more, these 2 biomarkers that characterize tubule cell function were each independently associated with risk of incident CVD. And again, the direction of these associations were similar as before. Higher urine alpha-1 microglobulin was associated with higher risk of cardiovascular disease, and lower baseline urine uromodulin was associated with higher risk of cardiovascular disease during follow-up. So once more here, it seemed that the function of the kidneys, rather than characterizing their injury, seemed to give more prognostic information in regards to risk of cardiovascular disease. Dr. Garamella, who led this work for our group, published this work in the European Heart Journal last year, and put together this very nice slide that I wanted to depict because it gives you some sense of the strength of these associations. So on the bottom here, you can see that we're looking at eGFR on the left, urine albumin here in the blue, alpha-1 microglobulin in the yellow, urine uromodulin. This is actually 1 over urine uromodulin to make the risk look in the same direction to compare strengths of association, and ultimately beta-2 microglobulin. And in this model here, all of these biomarkers are adjusted for all of the variables I showed you on the previous slide, as well as the other urine biomarkers. And the 2 points that I'd like to make in this slide are that both alpha-1 microglobulin, in this case shown as per doubling, and higher or lower urine modulin per halving, if you will, were about similarly strongly associated with risk of incident cardiovascular disease. And in fact, by comparison of point estimates, slightly stronger than albuminuria, even though these biomarkers were already adjusted for albuminuria. So it gives you some sense that these biomarkers are actually giving relatively strong associations with cardiovascular disease above and beyond the other risk factors. The second point is that eGFR had a very interesting signal here. Of course, lower eGFR was associated with risk of cardiovascular disease in SPRINT. But when we adjusted eGFR for these risk factors, these urinary tubule function biomarkers, the eGFR signal was essentially extinguished and brought all the way down to 1, suggesting that these markers are in fact telling us something about the health of the kidney and capturing some of the effect that we typically get with eGFR. But these remain independently associated with cardiovascular disease and appear to attenuate the association that we see with eGFR, at least in these data in SPRINT. So ultimately, we would love to have additional tools to characterize how we treat patients and how we diagnose different causes of kidney disease. And so we have an aspirational hypothesis here, one that is in its infancy and is certainly not definitively proven. But I wanted to share some exciting data about how the use of different biomarkers might be used moving forward to actually help us in diagnosis and prognosis in our patients. And so what I'll do to begin here is, again, use SPRINT data. In this case, we have biomarkers, again, in all 2,500 with chronic kidney disease at baseline. And as we designed our study, we elected to make repeat measurements in 1,000 individuals, and these 1,000 individuals were selected at random among the 2,500 individuals that we had at baseline. So they too all have chronic kidney disease at baseline, but represent a subsample of the 2,500 we had at the beginning of the study. And we did this at 1-year follow-up. So one of the things that is interesting and important to know about the SPRINT trial that I think many of you will be aware of is that while there were dramatic improvements in the primary endpoint in the SPRINT trial in terms of intensive blood pressure, lowering the risk of of future cardiovascular disease with a 25% risk reduction, and similar effects in terms of reducing all-cause mortality, and more recent data suggesting that intensive blood pressure control may also be very helpful for preventing mild cognitive impairment. Certainly, these hazard ratios here are all consistent in direction for very important clinical endpoints in older adults. But what was also observed in the SPRINT trial was that despite these improvements in these important clinical endpoints, there was higher risk of incident chronic kidney disease and higher risk of acute kidney injury with intensive blood pressure lowering. And it's been difficult for many of us in nephrology to square these two and try to understand what is best for individual patients if we're potentially giving benefit in one important endpoint, but God forbid, worsening their kidney function or their kidney function risk in the other. So among individuals with chronic kidney disease in SPRINT, it's important to look at the pattern of how eGFR changed during the course of this trial. And what I've tried to highlight in the red box on the left here is that the change in eGFR that occurred between these two arms actually primarily occurred early in the study. And as you can see, this divergence in the first 6 months, which to me suggested that this reduction in eGFR might primarily be a hemodynamic effect of more intensive blood pressure lowering, and might suggest that in fact this is not intrinsic kidney cell injury, but instead, again, maybe a hemodynamic effect. So we realized that with these markers that we had measured in the urine repeatedly, some looking at actual intrinsic cell injury in the kidneys and others looking at tubule cell function, could we actually differentiate whether or not there is intrinsic injury occurring in these individuals who are in the trial? And this work was led by Rakesh Malhotra, another assistant professor in our group. And I guess the larger research question is really what happens to the kidney during blood pressure lowering. And our hypothesis, again, is that eGFR generally follows the blood pressure, that this is a hemodynamic change in eGFR and would not be associated with intrinsic cell injury. Based on the data we had, we're limiting this again to individuals with eGFR less than 60 who started in the study. And we're going to compare the 1-year changes in eGFR, albuminuria, and then the 8 markers of tubule cell function and injury that I've already introduced to you earlier in the study, or earlier in the talk. So the first observation we made, which I think is very important clinically, is here what we did is we simply took the individuals with chronic kidney disease that were in SPRINT, and we characterized the magnitude of their change in blood pressure during the trial. So you can see we have 5 quintiles here, and this is limited to the intensive arm of the SPRINT trial. And so despite the fact that these individuals should have had a reduction in blood pressure, you can see that about 1/5 of them actually had no change or perhaps even an increase in their blood pressure. And in the other extreme, some individuals had quite a dramatic reduction in blood pressure. But by stratifying by quintiles, as you can see here, and then characterizing the associated change in eGFR, you can see this very linear relationship where if you had very little change in blood pressure, there was very little change in eGFR. And in parallel, if you had larger changes in blood pressure, that was accompanied by a larger decline in blood pressure. Larger decline in eGFR. Again, I think this is supportive data of a hemodynamic effect. Looking at the roughly 1,000 individuals that we had repeated urine markers of tubule function and injury in, this table here shows you what happened to their eGFR on the left and their albuminuria in the next bar here. And on the y-axis, we're comparing the effect change in the intensive arm that had intensive lowering of blood pressure versus those in the standard arm. And so the first bar shows you what I've already shown you in the larger population, that in these 1,000 individuals, those that were in the intensive arm also experienced a roughly 8 milliliter per minute decline in eGFR during the first year of the study with intensive blood pressure lowering. At the same time, despite a reduction in eGFR, which might suggest a worsening of kidney function if this was intrinsic, these individuals had a dramatic reduction in the quantity of albuminuria, roughly a 30% reduction in eGFR, a reduction in albuminuria in the intensive arm, despite a reduction in eGFR. Right? So again, these two markers are telling us something different about whether or not the kidney is perhaps injured or improving. eGFR is getting worse, albuminuria is getting better. What about the other markers that we evaluated? Well, the main message that we found in the study is that across these 8 markers of tubule health, none of the biomarkers were worsened in individuals that were randomized to the intensive arm of the study. None of these markers, for example, if you want to look at NGAL or KIM1, none of these markers of tubule cell injury were increased with intensive blood pressure lowering. So across a panel of markers, we could not find any evidence that the tubules were being damaged with intensive blood pressure lowering. So again, I think this is supportive data that likely the decline in eGFR observed in this trial may be primarily driven by hemodynamic effects. You'll see that 2 of the biomarkers were actually statistically significantly reduced in the intensive arm of the study. Now, this was not pre-hypothesized, but I think provides important complementary data for the hypothesis that we're putting forward here. And I want to remind you that both of these biomarkers that were reduced with intensive blood pressure control were these markers that I introduced to you before, alpha-1 microglobulin and beta-2 microglobulin. These were the markers that were freely filtered at the glomerulus and that we had measured because we thought that they would give us insight into the reabsorptive capacity of the proximal tubule. But of the 8 biomarkers that we measured, they're the only 2 that are actually filtered at the glomerulus. And so it's possible that if there's a hemodynamic effect that reduces blood pressure or the filtration at the glomerulus, that would also reduce filtration of these 2 biomarkers, and that we're picking that up in the urine with our biomarker panel. This is a corollary slide to what I showed you previously with the changes in eGFR in relation to the changes in blood pressure. So in this side here, what we've done is I've characterized the individuals that, based on quintiles of how much decline in eGFR they had in the first year. And in the green circles here, you see the individuals that had the largest decline in eGFR over the first year. And in all 3 of these cases of these biomarkers, whether it's albumin to creatinine ratio, beta-2 microglobulin, or alpha-1 microglobulin, the individuals that had the largest decline in eGFR actually had the largest reductions in the quantity of these biomarkers in the urine. So again, suggesting a hemodynamic effect. And of course, the opposite was also true, that those with the smallest changes in eGFR actually had the smallest declines in urine concentrations of these biomarkers. So, one exciting part of Dr. Malhotra's work in our group was the idea that this panel of biomarkers may ultimately allow us to differentiate hemodynamic causes of eGFR change from intrinsic cell injury. And again, here I've moved the box, but we have 4 markers that are all at least partially influenced by glomerular filtration and all decreasing in response to what we believe is a hemodynamic effect of the kidney. Whereas we have other biomarkers here on the right that mark tubule cell damage or intrinsic injury within the kidney, and none of these were altered in the 1,000 individuals that we're studying here within the SPRINT trial. So of course, we have ideas and additional hope to characterize this panel of biomarkers in other settings to see if they can characterize the causes for eGFR changes. And we believe it'd be a very useful tool if it could be used clinically when the creatinine bumps, to be able to differentiate whether or not that's a hemodynamic effect, a drug effect, or perhaps something more ominous where there's intrinsic injury within the kidney parenchyma. I want to acknowledge some exciting work that other groups are doing as this talk goes along. And I was very intrigued and excited about this study recently published that I wanted to bring your attention, which I think has a similar theme, although the design of the study and the biomarkers are in fact a little bit different. So these investigators enrolled about 250 individuals, and all of these individuals had kidney biopsies for acute kidney injury. And the biopsies were reviewed by 3 independent pathologists, and all 3 had to agree on a diagnosis of acute interstitial nephritis. So 32 of the roughly 250 biopsies had very clear acute interstitial nephritis. And the investigators hypothesized that they might be able to use urine biomarkers to identify a unique signature for AIN by studying cytokine concentrations in the urine. And in brief, 2 of the cytokines that they studied, urine TNF-alpha and IL-19, were identified as useful biomarkers to differentiate acute interstitial nephritis versus other causes of acute kidney injury that required biopsy. And here you can just see that visually. You can see TNF-alpha on the top panel and IL-9 on the lower panel. You can see the other causes of kidney disease and some healthy controls over here. And you can see that both of these biomarkers were substantially higher in individuals with acute interstitial nephritis, even as compared to ATN, GN, or other causes of kidney disease. And among those that had acute interstitial nephritis, there also seemed to be a dose-response relationship. So if you characterize the degree of interstitial infiltrates on these biopsies from normal, mild to severe, you can see that the concentration of urine TNF-alpha goes up with increasing severity of interstitial infiltrates. Same for IL-9. If there was tubulitis, the same idea, these biomarkers were higher. If there was greater eosinophilic infiltrate, again, a similar story. But again, here, if you characterize the amount of tubule injury, there was no clear signal in these biomarkers, again, suggesting that they give insight into a unique pattern of injury from acute interstitial nephritis. And lastly, and I think moving closer to the clinical arena, they compared the impact of these biomarkers on the appropriate diagnosis. You can see the pre-biopsy clinician diagnosis in terms of what the pathologist actually found, given A1 or an AUC of only 0.62, but when combined with this two biomarker panel, substantially improved the area under the curve, suggesting that these biomarkers helped tremendously in obtaining the right diagnosis of acute interstitial nephritis. So to summarize, tubulo-interstitial damage, fibrosis, and dysfunction, I think are common findings on kidney biopsy. I think they're very prognostically important, and yet, unfortunately, I think we are still blind to these if we rely on eGFR and albuminuria alone, except for the rare instance where we do kidney biopsy. In our work to date, markers of tubule cell dysfunction, in particular, seem to be particularly strongly associated with CKD progression and cardiovascular disease. I've shown you our data evaluating alpha-1 microglobulin and urine uromodulin. Others are working with serum bicarbonate, urine ammonium, and I think there are yet additional markers that can give us other aspects of what the tubules do that may be very important for defining prognosis and expanding the way we look at the health of the kidney. I think emerging biomarker panels suggest that we can differentiate hemodynamic versus intrinsic causes of creatinine elevation, and ultimately it might allow us to differentiate different etiologies of AKI, as in the AIN example. So the way I am thinking about this now, the way that I hope that we might be able to move as we approach this, is that perhaps we can think about a broader assessment of kidney health that assists us in diagnosis and treatment, the same way that we currently use a liver function panel in clinical practice. And I've shown here just my shorthand of how I record liver function abnormalities when I'm rounding with my team. But I want you to stop and think for a moment, if you're a clinician, about what you might think the etiology of liver injury is in a patient who is hypotensive after a hemorrhage, for example, in the ICU, and you see them the following morning with very high AST and ALT, but relatively preserved other abnormalities in their tubule or in their liver panel. This to me would suggest shock liver. And so just by comparing the clinical scenario and the relative concentrations of the biomarkers, we can get insight into the likely etiology of their liver disease. Take another patient that may have obstructive jaundice and has very high total bilirubin and alkaline phosphatase, but relatively preserved AST and ALT. And again, just the pattern of these biomarkers one to the other might give us some insight into what's happening in the liver. And as a third example, take the patient with cirrhosis who has relatively preserved other markers of liver function, but decreased synthetic capacity with a low albumin and an elevated INR. Once more, this panel of biomarkers, comparing them side by side, gives us immediate insight into the likely etiology of their liver disease, just based on blood tests in this case. And so I'm hopeful that we can follow that same pattern and ultimately have a broader assessment of kidney health that will help us improve diagnostic accuracy for the causes of AKI and CKD, might provide us non-invasive methods to improve prognosis, and ultimately might allow us to monitor changes in kidney health over time. For example, to tell us why creatinine is changing, or if we know why and we make a therapeutic maneuver, for example, prednisone for acute interstitial nephritis, that we can actually monitor the response to those therapies without requiring repeated biopsies and know that we're making a difference somewhat sooner. My main message is perhaps it's time that we move beyond serum creatinine and albuminuria and consider a broader assessment of kidney health. And with that, I want to thank you for your attention, and I want to acknowledge my close collaborator and friend, Mike Schlipak, who was a co-principal investigator in this research grant, the generous support we received from the NIDDK, all the trial participants and the other investigators of the SPRINT trial, and our respective institutions. Thank you so much for your attention.
Thank you. That was great. So we're going to move on to my talk, and then Secretary Eric Hogan will be on next after me. So I'm going to first want to just thank Jessica Joseph for all of your incredible efforts for making this happen, for your perseverance, your incredible hard work, especially over the last 2 weeks. Thank you to our chair, Mark Parazella, for your leadership, and to the co-chair, Mitch Rosner. Thank you to all of our program committee and the faculty. This has not been easy for anyone. Thank you for all of your sacrifice for making this happen. It's never easy to be the first, but I do think that this is really groundbreaking, and thank you again. To all of the NKF members, supporters, and staff, to our board of directors, our corporate sponsors, to our program committee and all of the program committee faculty, and most importantly, to the patients and families that we serve, along with all of the healthcare personnel who take care of our patients, this talk is about you. If you're listening to this talk, you must be someone who spends a lot of their time thinking about kidney disease. You spend most of your days, many days and weekends, nights, even holidays, thinking about kidney disease, taking care of difficult patients with kidney disease, researching kidney disease, and advocating for a very vulnerable patient population. And your efforts, the fact that you've been leaning in, has made a huge impact on the nephrology community. And we've had an incredible year. In July of 2019, the Advancing American Kidney Health Initiative presidential order was signed. And with one stroke of a pen, our highest priorities were actually made into public policy and national directives. And 2020 was going to be our year, the year that we increase awareness of kidney disease, the year that we put kidney disease in the minds of many more Americans, and we put kidney disease in the minds of primary providers in order to prevent kidney disease, detect it earlier, and prevent end-stage renal disease. And we had incredible traction because of the Advancing American Kidney Health presidential order. But our traction has been interrupted by a global pandemic that has hit our society with such force never seen in our history. And at this time, it is incredibly critical at this historical time that you fully understand and you fully embrace the impact that you can and will have on patients' lives and their well-being and their safety, as well as the well-being and safety of yourself and your family. It is critical that you think of yourself as a giant, that the kidney community awakens the giant within. The COVID-19 epidemic is very unique. It's unlike any other battle or tragedy that any of us have ever experienced, because it affects every single one of us, regardless of age or race or socioeconomic status. It affects all of us. Millions are now out of a job. Thousands of people have been hospitalized. And as of this morning, over 1,000 people in the US have died of COVID-19. Our patient population is the population that is most vulnerable to COVID-19 with bad outcomes. And now the most basic activities that our patients do, like going to the grocery store, visiting with family and friends, or going to a dialysis unit, is really, really scary. And we know that almost half of all the infections in the US, unique to other countries, are actually occurring among people over the age of 50, and they're being hospitalized. In other words, the bad outcomes associated with COVID-19 within the US do not appear to be solely limited to the elderly or people with comorbid conditions. And healthcare workers who are on the front line are most at risk, and many lack the needed patient protective equipment, which makes them at highest risk. At no other time over the past century has it ever had more risk to be a healthcare worker. Over the next several weeks, it's likely that the number of COVID-19 cases will continue to increase before we see a plateau. Even if we strongly enforce social distancing, we quarantine those infected, and we quarantine those who are exposed, it's going to take a long time to get past this epidemic. And this epidemic has completely disrupted how we manage our chronic diseases. In the past, most of us spent majority of our time addressing chronic diseases. But now, elective surgeries are completely canceled. All of the outpatient visits are canceled, and we're managing chronic diseases as an outpatient by telephone alone. And all of this has occurred. The changes have occurred so rapidly, within weeks, rather than months or years, which normally gives us time to prepare. So it's incredibly important that we think of ourselves as giants, because we are. We're a community of giants. We're advocates and providers who are not afraid to disrupt the status quo. We're not afraid to take big steps. We are a community that, no matter if a global epidemic that has hit every single continent in the entire planet except for Antarctica, is going to keep us from fighting for our patients with kidney disease and continuing the battle to improve the lives of all patients who are suffering with kidney disease. I use the word giant because giants are very tall in stature, and they can see past their obstacles. And because they can see past their obstacles, they're not afraid to take big steps. And when they take big steps, they're also not so concerned about stepping on other people's toes, as long as the big steps they are taking are the right ones. They also are very tall in stature, and they're able to elevate others. They're able to see higher and encourage others to see farther and think taller. And our history is really built on the shoulders of giants. And let me just tell you a story of Wilhelm Kolff. Dr. Kolff was the youngest and unpaid assistant at Groningen University in the late 1930s. And he had a patient who was 20 years old who died of kidney failure. After that 20-year-old man died, he knew that if he had just had an ability to lower urea, he would have been able to save that young man. And so he thought about it, and he went and took some sausage casing. He filled it with blood that had urea in it. And then he took that sausage casing with urea and put it into a bath of saline. Within 5 minutes, all of the urea that was in that blood had diffused across the sausage casing into the saline. And the concept of dialysis was born. But Dr. Kolff's life was extremely disrupted by World War II. The Netherlands was invaded by the Nazis, and the Groningen University was taken over by the Nazis. And all of his Jewish colleagues were ejected, and this infuriated him. So he left a university setting and went to a small hospital in Kampen. And at that hospital, he had no research funding. He had no support, but he never left that dialysis machine thought away. He used parts from downed airplanes. He used parts from washing machines. He used an old tin drum, and he used sausage casing to create this dialysis machine. But then he was in The Hague, which is a city not too far away from the Kampen, at the time that it was bombarded, heavily bombarded, and it caused massive casualties. But he was the one who took charge to create the very first blood bank in order to save lives. Now, he also never gave up on that dialysis machine, even when it failed over and over and over. In other words, he dialyzed not 1, 2, 3 patients that died, but 16 people that dialysis machine failed. But the 17th patient was Sophia. Sophia survived kidney injury because of his dialysis machine, and she lived another 7 years. And Dr. Kolff was also part of the Dutch resistance. He went and hid patients in his own home, risking the life of himself and his wife. And he hid patients in the hospital, pretended that they were sick and that he was their physician. And because of his actions, over 800 Jews and dissidents were kept from being put in concentration camps and murdered. After World War II, he took his dialysis machine plans to the United States, and he gave them to George Thorne at the Peter Bent Brigham Hospital, who then further developed a machine with the transplant group, which led to the very first transplant center in the United States. He never asked for a patent for any of his inventions, including the dialysis machine, because he wanted to make sure it was available for all patients. Another person who took big steps, but she probably never thought of herself as a giant, was Ada de Bode. Ada had a young son who was stricken with nephrosis, and at that time, they had no cure. So just a couple months after he was diagnosed, they created the Nephrosis Research Foundation in order to find a cure for her son. Now, they did not find a cure for her son in time, and he died at the age of 4. But she persisted, and they ended up finding a cure that did cure many other children who had this disease. And her research foundation became the National Kidney Foundation in 1964. And in the 1960s, the National Kidney Foundation got federal grants from the government to develop education programs across the country to teach people how to do dialysis. Because remember, in the 1950s, after World War II, Kolff had brought over this dialysis machine that was further developed at the Peter Bent Brigham Hospital. So dialysis was then blooming, but it was because of that National Kidney Foundation that she started that they taught people how to do dialysis, and dialysis spread throughout the country. And the seminal event of that early National Kidney Foundation then was the signing of the Social Security Amendment Act in 1972 by Richard Nixon, which then allowed dialysis to be used for patients across the country, no matter what their socioeconomic status was, no matter what their level was in society. And she probably never would have imagined then what happened further as the National Kidney Foundation continued moving on. In fact, the very first guideline to promote optimal care for patients with dialysis was done by the National Kidney Foundation. And over the next 20 years, many other guidelines have been created that went for all aspects of chronic kidney disease. And while many other societies have created guidelines, know that the National Kidney Foundation was the first. In addition, the National Kidney Foundation produces many patient education materials, and of course they do meetings like this to educate providers about the most latest and greatest research in kidney disease. And the National Kidney Foundation has screening events, they have advocacy events, they have fundraisers across the entire United States. She probably never dreamed that the National Kidney Foundation would have such a domino effect on the nephrology community. And something that is really prescient is the fact that about 2 years ago, the National Kidney Foundation did a home dialysis conference. And they brought together patients and providers to discuss how can we get more people to dialyze at home. Given the COVID-19 epidemic, it was completely prescient. In addition, the National Kidney Foundation had a consensus conference to try to figure out how we can use more of the kidneys that are discarded. Again, trying to promote transplantation. But both of those conferences, in addition to policy efforts that were going on without anyone really bragging about it by the National Kidney Foundation, had tremendous impact. This is Dr. Michael Choi, who is the past president of the National Kidney Foundation. Over here is Tanya Saffer, who is a former NKF policy staffer. This is Secretary Azar, and this is Adam Bowler, who is the former director of the Center for Medicare and Medicaid Innovation. And then all of this led up to the Advancing American Kidney Health Presidential Order in 2019. The presidential order had three major things. Number one, to decrease the number of people who are developing end-stage renal disease. And number two, to increase the number of people to get home dialysis or get a transplant. And number three was to double the number of kidneys available for transplant. And let me just talk to you about a new and really exciting initiative that will be, much more information will be given by Dr. Leslie Inker tomorrow. And of course, her session will be recorded. But for those of you who are interested in doing any form of research on kidney disease, please take note of the patient network. It's a national registry of adult patients with all stages of kidney disease. It's a non-interventional, web-based, retrospective, and prospective longitudinal initiative. Subjects will be enrolled by wide recruitment methods directed to the general market and closed systems, such as health networks or medical centers. Patient onboarding will consist of the submission of a signed e-consent, followed by creation of a unique identifier. And then the registry will link patient-centered data on the health history and outcomes and preferences with clinical and laboratory data obtained from the electronic health records. Data will be entered or uploaded in the web-based NKF Patient Network platform. And then data will be available to both patients and the scientific community to complete studies which aim at improving the knowledge and treatment of kidney disease. And the goal is to roll 50,000 people with kidney disease into the patient network. Now, as part of the Advancing American Kidney Health Presidential Order, and in partnership with CVS Health, the Department of Health and Human Services, and with American Society of Nephrology, a couple of weeks ago, the NKF launched the Are You the 33% campaign. And while it enjoyed early success, due to the COVID-19 pandemic, it was halted. But there's some really great statistics to show that this is going to be successful when it's relaunched. On World Kidney Day, 3,000 people took the quiz. And to date, almost 14,000 people have taken the quiz. Generally, media impressions range from about 12 to 20 million, but this time media impressions were 138 million. But in order to be sensitive to the COVID-19 epidemic, the National Kidney Foundation removed any social media posts that had anything to do with crowds or telling people to go to their primary care doctor. So the plans are to relaunch this campaign in September in conjunction with the National Hispanic Heritage Month. And we would like to say thank you to our corporate partners who helped make this campaign possible. CVS Kidney Care, AstraZeneca, Otsuka, Tricida, Health.io, and LabCorp. So you can see that over the past year, we took big leaps and we got really, really big traction. And you can look at this painting, and maybe you've seen this before, and we usually use it to describe it when people are standing on the shoulders of our mentors, on the people who've gone before us, like Ada DeBold and Willem Kalf. They are our giants in nephrology, and we stand on their shoulders. Because of the work that they did, we stand taller. The nephrology community stands taller. But I ask you to look at this differently. I ask you to see yourself as the giant and to see the future of nephrology standing on your shoulders. The future social worker, the future dietitians, the future nurses and nephrologists, the future researchers, the future advocates, and the future patients. Because we have big problems that we need to address immediately and moving forward. For example, 80% of our patients on dialysis still get dialysis in center, in these center units that are often in storefronts. And now with the COVID-19, you can see how critical it is for us to try to get more patients at home. And while thousands of patients have been transitioned from in-center units to home dialysis over the past year, it's still not enough. For those people who want to stay in in-center dialysis units, then it's imperative that we make sure that they are protected and they get the care that they need. And if they get COVID-19 infections, they're still able to get dialysis. But at the same time, we protect other patients from getting infected, and we protect our healthcare workers. It's a critical issue. The other issue has to do with transplantation, because that is our ultimate way of treating kidney failure. And kidney transplantation remains a waiting game. There's over 100,000 people who are waiting for a kidney transplant. And every single month, 3,000 people are added to that transplant wait list. And every day, many people die waiting for a kidney transplant. Many of the organs that are procured that potentially could be transplanted into patients are discarded. And we lack reasons for why these kidneys are discarded. And another issue is that there's huge silos of care, which in my opinion have worsened over time. We have the transplant team, we have the treating the general nephrologist, and then we have the patients. And these silos are not talking to each other. How can we determine the optimal kidney to transplant a patient if we're all not communicating together? In December of 2019, the National Kidney Foundation convened a group of experts to ask them, what can we do to maximize transplantation in the United States? And they had many ideas, but there was one idea that kept coming up over and over, and that had to do with chains, kidney donation chains. That's when you have a patient who needs a kidney, they have a donor, but that donor cannot donate to that particular patient because they're incompatible. But they would be willing to donate to another patient who's in a similar situation. But the problem is that these donor chains require a lot of organizational structure. They have complex consent forms and protocols, and it's not routinely available across the United States. We really need to make sure that these type of kidney chains, which can create miracles in certain areas, not be limited to major transplant centers, and there should be access to donor chains throughout the United States. The other issue has to do with the cost of immunosuppressions. So we know that immunosuppressive medications are only paid for by Medicare for the first 3 years. And we also know that many of our patients ration them after those 3 years, which leads to earlier graft loss and then need for a second and third kidney transplant, which just means another person is going back in that waiting list. A recent Budget Affairs analysis showed that if Medicare covered immunosuppressive medications, they would actually save $300 million over 10 years. I don't understand, if you're gonna pay for a transplant, you need to also pay for the immunosuppressive medications that maintain that kidney transplant. It's gonna be cost savings. And another major issue that continues to be the thorn in our side is the fact that most patients with kidney disease are not aware of it. If they're not aware, how can they maximize self-management? If they're not aware, how can they be getting the education they need, the medical nutrition therapy they need, or the medications that they need? And then this just leads to the fact that if they're not aware, they're not getting interventions, and they're more likely to end up on dialysis. And then when they end up on dialysis, they're not prepared. And that's just reflected by the fact that 80% of patients who start dialysis are starting with a catheter. It's just all part of the same problem. And then all of this leads to huge costs, which every year continue to escalate. Now we're at $120 billion per year for treating all stages of kidney disease, both CKD and end-stage renal disease. It's now 34% of the Medicare budget. It's just not sustainable. And the last thing is our major roadblock is lack of research funding, which has been ongoing for decades. And I want to say that the National Institute of Health has done a phenomenal job investing in cardiovascular disease for many, many years. And it has really paid off at the population level. In fact, over the past 50 years, cardiovascular mortality has declined by 80%. And I would say a huge chunk of that has to do with the research investment that the US made in cardiovascular disease. And research investment in cancer has saved 2.6 million lives since 1991. Yet kidney disease remains very poorly funded. In fact, cancer research is about 10-fold more than it is for kidney disease. And we know that about 34 million people with diabetes estimated now in 2020, and there's 37 million people with kidney disease. Yet research funding is almost 2-fold higher for diabetes than what it is for kidney disease. And this all leads to low levels of research for kidney disease, which has been going on for decade after decade after decade. So nephrology is the lowest bar here. All other medical specialties do more research and have more research funding basically than us. And then what that leads to is that we are not experiencing the benefits of decreasing mortality and improving survival for our patients as compared to patients with cancer and cardiovascular disease. There's a huge inequity here. The last thing about low research funding is that it's really having an impact on our ability to recruit people to do nephrology research. And at some point in time, people doing research in nephrology, they're going to be an endangered species unless this lack of funding is addressed and addressed quickly. So I end here, and I end with this picture again of the giant, because you are the giant, and the future of nephrology lies on top of your shoulder. There are complex acute problems that we are going to struggle with, but we're all in this together. We're truly a community of giants.
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 To me, the phrase standing on the shoulder of giants reflects the fact that medicine builds upon its past, upon our history.
Standing on the shoulder of giants means that we can achieve big things by standing on the people who've done big things that came before us.
There's no way that we would have gotten to this point with so much focus on kidney health as we have right here and now without standing on the shoulders of giants like the National Kidney Foundation.
The National Kidney Foundation is affecting change really through the Advancing American Kidney Health Initiative that is the culmination of years of NKF policy work.
Two components of the initiative are to improve utilization of home dialysis and to increase transplantation.
It's created a framework that allows the healthcare industry, the federal government, to prioritize kidney disease, to advance research, to advance innovation, to advance best practices, to increase quality initiatives, to increase spending, and really have a platform that allows patients to advocate on their behalf in a much more effective way.
The success of moving anything forward is going to demand that the patient's voice be involved. That's really where the National Kidney Foundation, I think, stands as a leader, and no other organization can do that in the kidney space.
The Kidney Patient Summit is an excellent opportunity for patients to get together, to network, to create energy, get on the hill, and really tell our stories.
Research right now is done on patients with kidney disease. We want research to be done on people with kidney disease. The National Kidney Foundation is establishing the first patient network for patients with chronic kidney disease. We hope that everybody with kidney disease looks to the patient network as the place to go to learn about kidney disease, to participate with kidney disease research, and to talk to other people.
The National Kidney Foundation has done a lot of tremendous things to try and promote particularly living donation. Their program, The Big Ask, The Big Give, has been a real win in trying to expose patients and programs to opportunities to help identify living donors.
The National Kidney Foundation has led the way in many respects in terms of identification of kidney disease, improving the care of patients with kidney disease. They have been a giant in the care of kidney disease patients for decades.
We are standing on the shoulders of giants, and now it's our time to leave a legacy. It's our time to go from helping thousands of patients to actually helping millions of patients, to really identifying and recognizing that kidney disease is a public health crisis and working rapidly to address that crisis. That's our opportunity, that's our legacy.
So I end here, and I just want to say thank you for everything you do to fight kidney disease. And thank you for everything you're going to do to fight kidney disease. Thank you so much for being kidney giants. I hope you enjoy the rest of the meeting. Thank you so much for being here. I'd like to introduce you to our keynote speaker, Eric Hargan, the Deputy Secretary of the Department of Health and Human Services, who has helped lead one of the nation's most comprehensive kidney health federal policies in the last 50 years with Advancing American Kidney Health Initiative. NKF is honored to be a part of this national effort to better the outcomes for all kidney patients, and we want to thank the Deputy Secretary Hargan for his incredible work for kidney patients. As Deputy Secretary, he is the Chief Operating Officer and is responsible for overseeing the day-to-day operations and management of the department, in addition to leading policy and strategy development. He developed his BA cum laude from Harvard University and his JD from Columbia University Law School, where he was senior editor of the Columbia Law Review. Mr. Hargan also taught at Loyola Law School in Chicago, focusing on administrative law and health regulations. So please welcome Deputy Secretary Eric Hargan. Welcome and thank you for being here.
Now, right at the start, I want to thank not only our patient innovators we're recognizing today, but also the leaders of the National Kidney Foundation and the American Society of Nephrology for teaming up with HHS to make so much of our work possible. I know that COVID-19 has been at the forefront of the minds of the American people these past few weeks, and especially on the minds of people who have serious underlying medical conditions like kidney disease. Please know that protecting vulnerable communities is a top priority for this administration during this national crisis. Patients with kidney disease are in one of the riskiest categories because many of them need to leave their homes to receive care multiple times a week. To America's kidney patients, I want to say we will do everything we can to help make sure that you can receive the care you need in the safest way possible. Last week, on behalf of Secretary Azar and the entire department, I held a call with a number of kidney stakeholders to get an update on what's happening on the ground for kidney patients and what we ought to be considering to keep kidney patients safe. We set up an email address to receive these submissions, kidney-COVID-19, that's kidney-COVID-19 at hhs.gov, and the deadline for this round of submissions was yesterday. We've already begun receiving these responses, and I encourage you to send in thoughts either personally or on behalf of organizations. I also want to reassure you that while our response to the COVID-19 pandemic is our top priority here at HHS, we remain laser focused on our other initiatives like improving the quality of care and outcomes for those suffering from kidney disease. That's part of what I'm doing here today. It is especially important to keep that focus on advancing kidney care because I believe we're on the cusp of a major revolution in how America treats kidney disease. And certainly, we would not be at that point without all of you who have joined me today. Whether you're a patient with kidney disease yourself, a health professional who works with kidney patients, a researcher, or involved in supporting kidney patients in some other way, I and we are grateful for what you do. You and your dedication to American kidney health are one of the main reasons I have hope that we can deliver on our shared vision. Now, as some of you may remember, the first place where we began laying out this administration's vision for kidney care was the National Kidney Foundation's patient gathering in 2019. We were told that just identifying all the problems in American kidney care and all the opportunities we have to improve it was more attention than federal leaders had paid to this issue in a long time. Well, we followed up that diagnosis with a plan for action, President Trump's executive order on advancing American kidney health, and the initiative it launched at HHS. The execution of that plan is well underway, and I want to take a few moments to give you a brief update on it, and then I'll announce the 25 winners of our KidneyX Patient Innovator Challenge. The President's plan has three parts. First, more efforts to prevent, detect, and slow the progression of kidney disease. Second, more options for treating kidney failure from both today's technologies and those of the future. And third, more organs for transplants. On the first prong, last fall, as I'm sure many of you know, Secretary Azar launched a partnership with the National Kidney Foundation and the American Society of Nephrology to educate Americans on how they can improve their kidney health. This kind of collaboration is vital if we want to increase the promotion of early identification, treatment, and management of kidney disease. These efforts to educate and inform the public to prevent kidney disease have to be supplemented by changing the incentives around kidney care. That's why we've launched 4 optional payment models, known as Kidney Care Choices, expected to enroll more than 200,000 Medicare patients in arrangements with new incentives to prevent the progression of kidney disease and manage kidney patients' health. Better payment incentives are also a powerful and necessary piece of transforming the care kidney patients receive once they do need dialysis. We're continuing to review and consider comments on a model known as ESRD treatment choices, which is designed to give a significant portion of dialysis providers new incentives to encourage dialysis in the home. Changing our payment systems could also spur adoption of new cutting-edge technology that make in-home dialysis easier and more affordable. And new kinds of technologies could help us in emergency situations like the one we're facing right now. Our Office of the Assistant Secretary for Preparedness and Response has been in the process of testing out portable dialysis machines for use after natural disasters, an effort that was spurred after our government's response to 2017's devastating hurricanes. The kind of capabilities we need for response in disaster settings caused by hurricanes, like the ability to use publicly available water rather than medical-grade water, will be useful in expanding portable dialysis access for Americans in all kinds of other situations. That includes potentially a pandemic situation, like today, where we'd love for more patients not to have to go into a dialysis center. Particularly during this crisis, we're working to explore every possible site of care for dialysis patients. And as technology continues to afford us more efficient delivery models, we can look beyond the traditional categories of homes, dialysis centers, and hospitals to consider options such as clinics, community centers, and mobile dialysis units. Within all of the payment models we put forth, we're not just going to pay for better, more person-centered prevention and dialysis, we're also going to provide new incentives to encourage transplants. Today, we have a system that pays for dialysis rather than transplants. So what we get, of course, is lots of dialysis and not as many transplants as we should have. It's time for that to change. Transforming lives through more kidney transplants will also require expanding the supply of transplantable organs, and we're hard at work on that too. There were a number of helpful steps laid out in the President's executive order that we've begun to take action on, such as reforming the metrics by which we judge organ procurement organizations and expanding the support we provide for living donors. We issued proposals on both of these fronts from HRSA and CMS in December. The comment period is closed, and we're reviewing those comments now. We want to do everything we can to improve America's transplant system, from supporting those who chose to be donors, to managing the procurement of organs, to improving the care received by transplant patients. We've also brought that kind of collaborative spirit, looking at all possible areas for improvement, to something I know many of you are familiar with, KidneyX, our partnership with the American Society of Nephrology to accelerate development of breakthrough technologies. In just a moment, I'll have the honor of announcing the Category 1 and Category 2 winners of our Patient Innovator Challenge, which is an important step forward in recognizing the vital perspective of kidney patients. You all know what a burden kidney disease can be on patients' lives, and I know that all of you want nothing more than to change that, in part by putting patients in control. You want to build for kidney patients what President Trump envisions for all Americans, a system that's personalized, patient-centric, puts you in control and treats you like a person, not a number. With your help, that's the kind of system we're going to build for kidney disease, and it's going to deliver what we all want for America's kidney patients, better health and longer lives. And I look forward to working with all of you toward those goals. With that, it's now my pleasure to announce our KidneyX Patient Innovator Challenge winners. We have 25 winners to announce and celebrate today, plus dozens of other excellent submissions. And so thank you to everyone who participated. These awards are a tribute to the hard work that so many men and women across HHS and outside HHS have been doing to advance American kidney health. And I want to thank everyone who submitted ideas and took part. As most of you know, the KidneyX Patient Innovator Challenge contest, funded by the National Kidney Foundation, invited individuals, communities, businesses, institutions, and not-for-profit organizations, among others, to submit ideas on how to improve therapeutic options and quality of life for people living with kidney diseases. A panel of judges and reviewers spent months reviewing the more than 120 submissions to select 10 winners in Category 1, which are for solutions already tried or put into practice, and 15 winners in Category 2, which is for ideas for solutions not yet created. I'll announce the winners in alphabetical order. Each of these 10 winners in Category 1 will receive $4,000 each. So, without further ado, Category 1. Ann Chokas of Great Neck, New York, for designing a smartphone app to monitor blood test results. Chris James of Cardiff by the Sea, California, for creating a way to extend the life of a kidney removed for transplantation to give surgeons more time to access the organ. Deepa Kariyawasam, of London, England, for creating kidney patient diet booklets geared towards minority cuisine. David Karaguntla of San Francisco, California, for creating a device to monitor fluid levels in dialysis patients. Sarah Lee of Baltimore, Maryland, for creating a device that disinfects tubing for peritoneal dialysis. Robert Richter of Coconut Creek, Florida, for creating a device to help a one-handed vet administer home dialysis. Chelsea Roman of Sacramento, California, for creating a 3D printable wrist cuff to secure needles used in home dialysis. Lana Schmidt of Liberty, Illinois, for using a state-funded home aid program to hire someone to help her with home dialysis. Deborah Stanzik of Twinsburg, Ohio, for creating clothing suited for dialysis patients. And John Vito of Rochester, New York, for creating a video cooking series for end-stage kidney failure patients. So congratulations to all the Category 1 winners. Now, again, without further ado, moving on to the second group. Each of our 15 winners in Category 2 will receive $2,000. And the winners in Category 2 are Brian Bender of Raleigh, North Carolina, for a home-use device in development to track sodium levels in urine. Andrew Brookins of Denver, Colorado, for a proposal to open a home dialysis education center to train patients. Chandra Chun of McDonough, Georgia, for a proposal to develop an online platform to help home dialysis patients. Anthony Clark of Wilmington, Delaware, for creating kidney food labels for kidney patients. Jacqueline Yanakoulis of Stoughton, Massachusetts, for developing a program to rent home dialysis cyclers for patients when they travel. Neil Chagedny of Kearneysville, West Virginia, for developing a toolkit for home dialysis patients to give real-time feedback. Varun Goyal of Carmel, Indiana, to develop an app to help transplant patients keep track of their medicines. Lonnie Green of Kennesaw, Georgia, to develop a peer mentorship program for dialysis patients. Mary Lou Hurley of Bloomingdale, New Jersey, to create a handout about transplants for patients to give to emergency room professionals. Daniel Marsh of Baton Rouge, Louisiana, to develop an open chair app to help patients find a real-time dialysis center that has an immediate opening. Sandeep Padala of Augusta, Georgia, to develop help for dialysis patients who are released from prison. Emmett Smith of Seattle, Washington, to develop a device to help with dialysis catheters. Ben Studdard of Nashville, Tennessee, to create music videos to teach patients about medical terms. Cher Thomas of Galveston, Texas, to develop a program to link dentists with patients on the transplant wait list. Joyce Vergili of Kingston, New York, to create a device to monitor blood potassium levels. So, congratulations to you all, and thank you to everyone for taking part in this challenge. Everyone involved has helped us take a meaningful step forward towards empowering kidney patients to improve their own health and their own care. And let me close by thanking the National Kidney Foundation for adjusting the schedule today to allow us to recognize the winners, and thank all of you for adjusting your lives to help defeat COVID-19. By staying home and following the President's and CDC's national guidelines, you're playing a role in helping to keep fellow Americans, especially the most vulnerable, safe. And thank you also for your hard work and your drive to solve one of our country's biggest health challenges. And I look forward to working with many of you in the future, and please stay healthy and stay safe. Thank you.
Thank you so much, Secretary Eric Hargan. We really appreciate you coming and being involved. And for those of you who would like to know more about the KidneyX winners, please check out nkfclinicalmeetings.org. There is information about all of the KidneyX winners. These are patients, not nephrologists or things like that, who have developed ideas, and they're really exciting. So thank you so much, everyone, and I hope you enjoy the rest of the meeting. Bye-bye, everyone.